And when we start thinking about how these drugs play out in these biologically heterogeneous populations, we're seeing the same thing, right? The low risk, less proliferative P53 wild type patients do great. These are the same guys that did great with transplant, by the way. But the P53 mutated, more proliferative patients, these guys aren't doing so hot. They're progressing quickly, and when they progress, their survival is poor, exceptionally poor, around two months or so in our study, which I didn't put Peter Martin's multi-center review, but is around the same in his trial. You have this tail of around 20% where you can salvage, but the other 80% we really struggle with. These patients are often progressing within the first few months of taking ibrutinib, and again, I didn't talk about it in the presentation, but that opens up so many opportunities when we think about using MRD to guide, almost as an adaptive approach to guide the addition of other drugs, to start saying, how do I fix this problem? What can I put into this space once I know ibrutinib isn't going to cut it? So we not only have predictive things like P53 and proliferative status, but we actually have something else that we can use before we get to that 6-month endpoint where we're seeing those poor outcomes, meaning a month or two in, let's see where we're at. Let's see what we're accomplishing.